in future guidelines. So what we said in a recent paper that we wrote with Bill Bowden in The Lancet is that we need really to stick to these two major goals of OMT: reduce events and symptom control. And because prior trials show that PCI does not reduce incident cardiovascular events in the majority of stable angina patients, excluding of course those with prognostic sort of markers like left main or severe three-vessel disease with a reduced ejection fraction, and that chest pain treated conservatively largely improves over time, an optimal medical therapy first approach, we believe, is sound and evidence-based. Now the problem is, what exactly is optimal medical therapy, how long we have to persevere with medical therapy, etc., etc. So we propose that you need to persevere with optimal medical therapy for 3 to 6 months, adding medication, up titrating doses as it is reasonable. And such an approach to medical treatment for stable angina, we believe, is appropriate and medically justifiable, as in most stable angina patients, PCI can be safely deferred and reserved for symptomatic treatment failure. And I think this is important. So I know that what I'm proposing and what Ischemia proposes is time consuming, because patients would prefer a quicker fix. Just go for revascularization and everyone will be happy. But the reality is that there is no standard therapy. The reality is that we need to look at the different mechanisms, the different causes of ischemia in each of our patients. There are lots more than an obstructive coronary problem. So let's see how we would manage this patient, taking into account the findings by Ischemia and by the other studies and the meta-analysis previously. This is a 66-year-old man with exertional chest tightness associated with shortness of breath on moderate or mild exertion. He has no symptoms at rest. He had a history of type 2 diabetes and hypertension. He's an ex-smoker and quit smoking approximately 5 years ago. He has received treatment with metformin for his diabetes, ramipril, aspirin, beta blockers, and the calcium channel blocker combined, atorvastatin 40 milligrams to bring the cholesterol down. The problem is that he doesn't tolerate higher beta blocker doses for a number of reasons, mainly side effects. Physical examination showed the blood pressure, which was within normal, pulse 62. He's overweight with a BMI of 28. He has also some degree of peripheral artery disease. Her ECG shows sinus rhythm 63 beats per minute and no signs of left ventricular hypertrophy. An exercise test on the standard Bruce protocol went up to 8.5 minutes, 9.8 METs. He developed his usual symptoms, chest pain and shortness of breath at peak exercise with ST segment depression, horizontal, in leads B4 to B5, and in approximately 3.5 minutes, the ECG recovered, which is a marker of mild flow-limiting coronary artery disease. He was referred for angiography and for a cardiac MRI perfusion scan. The angio showed pretty clear focal coronary artery stenosis in the right coronary artery with a slightly reduced FFR, and the cardiac MRI showed that he also had subendocardial hypoperfusion, probably suggestive of microvascular dysfunction. So physicians who saw this patient thought that his glycemic control was still rather poor with metformin, so they added empagliflozin 10 milligrams once daily in the morning, and probably would plan to increase the metformin if necessary. Very strict lifestyle changes, and an exercise rehabilitation type of program. They considered the possibility of using DOACs for his peripheral artery disease and in the presence of coronary artery disease and his diabetes. But they were concerned about the persistence of symptoms despite conventional treatment. So because of the lack of symptoms, they thought that they had to add a second anti-anginal or even a third anti-anginal medication. But because of the coronary microvascular dysfunction and the diabetes, the optimal choice would be ranolazine. And they started with 375 milligrams twice daily, up to 500 milligrams twice daily, and up to 750 milligrams twice daily. And this way they addressed the obstructive coronary artery disease and the microvascular angina. They did not send this patient for primary PCI based on the Ischemia trial results. So optimal treatment of his sort of risk factors and optimal anti-anginal treatment, bringing into the equation a drug like ranolazine, which for them, at this point, for this patient, was a first-line drug because of the diabetes, because of the microvascular dysfunction, because of the intolerance to the beta blockers or the lack of possibility of using larger doses of a beta blocker. So, in relation to this patient, my take-home messages are these. They took a very careful clinical history to identify the mechanism of angina. They did not rush to treat the coronary artery stenosis that was quite significant at angiography. They didn't go for the quick fix. They spent enough time to implement optimal medical therapy. Importantly, they discussed with the patient. They explained to the patient that PCI was not going to improve his survival. PCI was not going to prevent a myocardial infarction. Therefore, the patient was prepared to take the medication. They realize and they believe that ischemic heart disease is a continuum and it's not just obstructive coronary artery disease. That's why they look for microvascular dysfunction. And they also consider that anti-anginals all have more or less the same efficacy. So they decided to go for a medication like ranolazine that tackle the problem that this patient was presenting in addition to the obstructive coronary artery disease. So when possible, anti-anginal therapy has to be targeted to the underlying cause of angina and ischemia before proceeding to revascularization. And as I said at the beginning of this talk, this approach to medical management of stable angina is appropriate and medically justifiable, as in most chronic coronary syndrome patients like this patient, PCI can be safely deferred and reserved for symptomatic treatment failure. Thank you very much.